Morning. We are going to talk about a comprehensive review of Tommy John reconstructive surgery, as well as improved rehabilitation strategies and new treatment techniques. The reason why I chose this topic is during my time as an athletic trainer at the University of San Francisco, I had 3 UCL injuries, all requiring surgery, that were experienced last year, and I looked at the prevalence not only with my team but also in the professional level and across the board in the sports medicine field, and realized that this is becoming a more common injury, and I wanted to study it further. So here we go. A little introduction. The prevalence of UCL injuries in the popular press, a report was done in 2003 that said that 1 in every 9 MLB pitchers has had UCL reconstructive surgery. And that was done in 2003, so that number has probably gotten higher. And there are roughly 350 major league pitchers in the professional level, so that is a very high prevalence rate. And because of the prevalence of injuries, an increase in Tommy John surgeries has been seen as well. Dr. James Andrews, as seen here in the bottom picture, has gone from performing less than 10 Tommy John surgeries per year to over 75 surgeries per year, and this was back in 2010 as well. So that number has possibly increased as well. And Brian Wilson there, the top picture, has seen Dr. James Andrews, who is the guru for the professional level in Tommy John surgeries. And this surgery has increased in recent history, the amount of surgeries, but so has recent improvements in treatment techniques and the surgical options available. And that is why I wanted to investigate that further. So a little background of Tommy John surgery. Tommy John was a professional baseball pitcher in 1963 to 1989. And he received the new innovative surgery from Dr. Frank Jobe in 1974 at the top. And the story goes that he injured his arm while pitching, heard a pop, and talked to the Dr. Frank Jobe there, seen in the picture on the top. And Dr. Jobe said, "You tore your ligament." And back in those days, there was no surgery to repair it. It was a career ender, and some people did come back from some rehab and time off, but Tommy just simply looked at him and said, "Well, doc, get me a new one." And he did, and in 1974 created the surgery now known as Tommy John surgery. And John had a very successful outcome. He went on to be the comeback player of the year the next year that he was pitching. And even Steven Strasburg there, noted in the bottom right, is one of the top pitchers in the major leagues right now. And if you look closely, you can see his surgical incision on his right elbow, throwing elbow right there. And in his last start, he actually struck out 10 guys. And again, is one of the top pitchers in the league right now. And just shows you that there is successful outcomes after this surgery. A little anatomy of the elbow. The medial elbow involves the humerus and the ulnar bones. And the ulnar collateral ligament is actually involves 3 bundles: the anterior bundle, posterior bundle, and the transverse ligament. But studies have shown that the anterior bundle is the main stabilizer against valgus force and is the most commonly injured ligament. Functional anatomy there, seen in the bottom left picture, the common flexor pronator group attaches to the medial epicondyle right on top of the UCL ligament. So these muscles provide a dynamic stability through their contraction, and they actually provide a varus moment against the valgus stresses that are seen during the throwing motion. And studies show that the flexor carpi ulnaris and the flexor digitorum superficialis are the main dynamic stabilizers during the throwing motion. As we talk about the thrower's elbow, overhead athletes are very susceptible to significant elbow injuries. Most commonly, significant injury is the UCL, tear of the UCL. And as seen here, baseball is not only the only sport that experiences UCL injuries. Volleyball players, American football quarterbacks usually, as well as javelin throwers, experience injuries to the UCL and the medial elbow. And as you can see in all 3 pictures here, most arms are roughly about the 90 degree of elbow flexion, and this creates a very susceptible moment for the elbow as the bones are unlocked and the muscles and ligaments are providing most of the stability. And this is where the shoulder goes into max external rotation and into a rapid arm acceleration and elbow extension. And this done repetitively creates a valgus stress that can cause injury. Breaking down the throwing motion here of a baseball player specifically, most UCL injuries occur during that cocking and acceleration phase. And as mentioned on the previous slide, during foot contact there, the arm cocking circled is where the shoulder is in max external rotation, and the arm acceleration is where the arm starts to come forward. So loading into external rotation and then rapidly accelerating into the arm acceleration phase of throwing is where most injuries occur because of that violent nature. UCL injuries, the main mechanism here is excessive valgus stress, as we've been talking about here. Throwing and overuse produce that sharp pain and create more of a chronic injury, tear that can happen over time. But most commonly seen is an acute rupture, which involves an audible pop heard by the individual themselves as well as others around them. So there's sharp pain during one specific throw, as well as the audible pop is the classic sign of a UCL injury. Upon examination, the clinician or athletic trainer wants to obtain the full history of injury and any injuries in the past to the elbow, as well as look for any emergent situations as far as fracture or signs of dislocation. And then they proceed into the range of motion to make sure and see what range of motion is available and what is actually painful. And then you assess the strength of the muscles around the elbow that cross the elbow and connect to the elbow joint. And then you get into the special test of the actual stability of the elbow, where you actually test the ligaments. And the valgus stress test is the most commonly used one, and you can use it in the full extended position, although the bones are in a closed packed position here and providing some resistance. But with the complete tear, you can still feel some laxity. But most commonly used is in the 30 degree or even 30 degrees of elbow flexion, or even the milking maneuver here seen in the bottom left picture, where the elbows anywhere between 70 and 90 degrees of elbow flexion, and that is actually replicating the throwing motion. And the ligament can be palpated and tested and dialed out into a valgus moment for laxity and pain. And when it's determined that the UCL has been torn, surgical options are available. The most widely used has been the figure of 8 technique used by Dr. Frank Joe back in 1974. And this first surgical procedure produced a successful result in Tommy John and involved harvesting a graft, usually from the forearm. And the palmaris longus tendon graft is the most common tendon used and is weaved through in a figure of 8 fashion through the holes drilled in the bones there, as you can see in the picture. And this actually produced an original success rate of only 64%, which was good for Tommy John, but not good for some other people. And so improvements have come over time, and the new procedure now more commonly used is the docking procedure there, which involves 2 smaller holes on the backside of the medial epicondyle there, seen, with sutures exiting instead of the actual tendon graft. And the tendon graft is through the ulnar bones, but then docked inside of the bone of the medial epicondyle, the humerus. And then the sutures are exiting through the smaller holes on top. This actually allows the ligament, the new ligament or tendon, to be fused inside the bone tunnel and become part of the bone as healing occurs, and has yielded better results, even upwards of 85%. Non-surgical techniques usually involve rest and rehab and a gradual throw-in program or return to play. This usually takes roughly 4 to 5 months, and no surgery is involved, and this is usually with a partial tear or just a minor sprain of the ligament. More commonly, I've been using PRP injections more recently here, and a lot of professional athletes have had successful outcomes, like Tiger Woods and Hines Ward for the Pittsburgh Steelers. But more studies that need to be done on the actual protocol and the efficacy and safety of the use of PRP injections. A lot of animal studies are available, or anecdotal stories of these professional athletes, but no hardcore clinical studies are out there that test it on sport-specific human subjects. When you get into the rehab, whether you get surgery or not, all rehab involves some type of immobilization, more commonly seen through the range of motion brace there, and you can adjust the range of motion available for the person, as well as therapeutic modalities to help break down scar tissue, increase circulation, and control pain levels and inflammation. This is done through ultrasound and ice and electric stimulation. And then as they progress, you get into more progressive resistance exercises, And this is where you use lightweight dumbbells and you do exercises that can be progressed accordingly based on the strength and pain levels. And then, again, like we talked about, we get into the throwing program and return to play guidelines. My personal preferences with rehab is using PNF techniques, proprioceptive neuromuscular facilitation, which combines movements of the shoulder, elbow, and wrist, and more commonly is seen with diagonal patterns across the body. And then you got manual resistance techniques, which seen here in the bottom picture of external rotation, side-lying external rotation. And you could accommodate the resistance and really target strength as well as endurance and lighten the resistance as you go through higher reps. So they're still getting work, but you're accommodating the resistance, and it really gets at proprioception, improved dynamic stability with this. As well as you want to target the flexor pronator muscle group, as the studies we mentioned before have seen that those are the main activators to provide that valgus stability in the throwing motion. The actual phases of rehab are seen here. Phase 1 is the immediate post-op phase from week 0 to week 4, and this main goal here is range of motion. You want to get the elbow out of the immobilization as soon as possible, but that doesn't usually occur till about week 4 or 6. And then you want to get passive range of motion of the elbow, active motion of the wrist, and even the shoulder inside the brace. And you want to work soft tissue mobilization of the scar and the muscles that are healing. Phase 2 involves the intermediate phase from about week 4 to week 8. And the goal here is strength, and in particular the whole kinetic chain. So now you start targeting the shoulder, the scapula, as well as still the elbow and the wrist. You introduce some PNF techniques, like I mentioned, that I love to use, as well as some other proprioception exercises and light dumbbell work to get into the resistive exercises. Phase 3 is advanced strength phase from about week 8 to week 13. And this main goal here is to produce strength and endurance, but specifically towards sport-related activities. And so you start including drills such as the Throwers 10, which are 10 exercises you can do every day or every other day. They involve like scaption or the full can motion, upwards external rotation, and as well as 0 degrees of shoulder abduction, internal and external rotation. And then you start to introduce plyometrics and medicine ball tosses against a trampoline or against a wall with the chest pass, the overhead pass, and start introducing more of that power and strength phase as they return to their activity. And phase 4 is the actual return to activity phase from week 13 to week 20 or beyond. And this phase builds on top of phase 1, 2, and 3. You still target all those goals, but you start to begin the interval throwing program with set distances and set amounts of volume. So you're not stressing the throwing motion too much too soon, but as they progress through the throwing program, they can gradually return to play and slowly become integrated back into the sport and practices and eventually full participation in games. Now, building on top of rehab are some prevention techniques, and some studies I looked at included Stevie Deblar here, the top left guy, featured on Real Sports with Ryan Gumbel, and he shattered his elbow and actually made a full recovery and improved his velocity through some of the rehab techniques of isometric contractions of the throwing motion here. As seen in the picture, he's breaking down that throwing motion and holding it usually against the resistance on a wall, as well as using a weighted sock throw to provide that co-contraction of muscles. Another study looked at bat training exercises. Most baseball players have access to bats and can use ulnar and radial deviation as well as contraction in circles, clockwise and counterclockwise. All of these exercises targeting that co-contraction of the forearm muscles to increase that valgus stability, as seen in the previous studies, that you want to target that flexor pronator group in the forearm muscles to really have strong strength and endurance to provide that resistance to the repetitive forces that are seen in throwing. But even with these prevention techniques and solid rehab, people will still tear their UCL, as seen in more recent studies, has become more and more prevalent. So that begs the question to see, is there other things that we can look at, like mechanics or the optimal throwing form? What can be done to do this? And this is where my proposed study comes in. And I want to look at applying platelet-rich plasma injections that we mentioned earlier, as well as biomechanical analysis of baseball players after UCL reconstructive surgery to see how the PRP can help, and analyzing the pitching motion can improve some of the optimal form that can lead to better outcomes following surgery, as well as less chance for injury. And my proposed study